Okay. So good evening to everybody. I think you're just coming back after the puja holidays. So today we'll be having with some echoes and angios and case scenarios. It's very important that you interact and try and answer the questions, and that's what makes the quiz interesting and informative. Okay. So let's start with the first question. So it's a 5-month-old baby who presents with breathlessness and failure to thrive. Okay, and on echo, this is what you find. So what does this echo show? So I need you to type into the chat box so that with your answers. What does the echo show? Anybody? Can you hear me? Okay, good. So there is significant TR. Okay, so yes, you probably call it severe TR. And if you look at the right ventricle, it appears to be quite hypertrophic, right? So there is right ventricular hypertrophy and significant TR. So this is the TR gradient, and what does the gradient indicate? What does the gradient indicate? The gradient is 107. Anybody? What does a high TR gradient indicate? High pressure TR. Okay, that means exactly. So the RV systolic pressure is high. Now, what are the reasons for RV systolic pressure being high? What are the reasons for RV systolic pressure being high? Right. So either there is obstruction or there is pulmonary hypertension, and the obstruction can be at multiple levels. It can be at the level of the right ventricular outflow tract. Even something like double chambered right ventricle, the TR can be elevated. It can be valvar, it can be supravalvar, it can be at the level of the branches. We're talking about obstruction. And then pulmonary hypertension, of course, it can be due to multiple reasons, and the high TR gradient could reflect either obstruction or pulmonary hypertension. Okay, so what are we seeing here? Can anybody tell me? So the same patient. So you can see that there is laminar flow in the right ventricular outflow tract. Okay, so there appears to be no pulmonary stenosis per se. Pulmonary valve appears to be pretty delicate and seems to be opening fine. There is no flow turbulence. MT is okay, maybe mildly dilated. Okay, but it's not grossly dilated. What else can you see? Which appears a bit unusual, and it explains the high, the pulmonary hypertension really. So, from the looks of it, it doesn't appear to be that there is any outflow tract obstruction. Okay, and somebody says AP window. You're kind of close, but this isn't an AP window. So you can see that, you can't see any communication between the aorta and the MPA here. Normally, in an AP window, there is a communication between the aorta and either the main pulmonary artery or the proximal branch pulmonary artery. There is no pulmonary stenosis here. There's no flow turbulence. Flow is quite laminar. Any other? Exactly. Correct. Yes. So basically, the RPA appears to arise from the aorta. So this is anomalous origin of the RPA from the aorta, otherwise known as hemitruncus. Hemitruncus is a very kind of old-fashioned and perhaps a colloquial term, but this is anomalous origin of the right pulmonary artery from the aorta. What will you do for this child? What will you do for this child? We can give quick answers and we can get through more. Exactly. So need surgery and reconnection of the RPA into the main pulmonary artery. Okay. So this is a better picture, it's a still picture, and you can see this is the aorta, this is the pulmonary artery. You can see that the RPA is coming off the aorta. This frame, it is being measured. Okay. Okay. So tell me, what does this angiogram say? You can describe the angiogram if you want. Okay. So injection into the IVC using a pictorial catheter, which is a good angiographic catheter with side holes and an end hole. So this IVC opens into an atrium. So what is the first thing you notice about the IVC? And also exactly, correct. So the heart is on the right side of the chest. The apex appears to be pointing to the right. So this is dextrocardia. Patient has had surgery. You can see the sternal wires. So this is a post-operative patient. The IVC is to the left. And if you wait till the end of the run, you can see the aorta filling in the late phase, right? So there is some communication, either a VSD or some way by which the dye is actually getting back into the aorta. So you can see that the aorta fills here. So the aorta is to the right and the IVC is to the left. So this is situs inversus dextrocardia in a post-operative patient, and the IVC is opening into the atrial mass. This is not a Fontan circuit like somebody had mentioned earlier. And this is the right atrium. You can see the right atrial appendage here, right at the top. So this is situs inversus dextrocardia. Okay. So this is actually the same patient. Somebody's microphone is on. If you could just all mute your microphones. So this is the same patient. What do you see here? Correct. So this is an angiogram with a pictorial catheter into the left-sided SVC, which is connected to the pulmonary artery. So there's been a Glenn operation that has been carried out. You can see the sternal wires. The patient has dextrocardia, as we previously noted. Okay. The branch pulmonary arteries appear to be adequate, and there's good arborization with good pulmonary venous return. In addition, you also see venous collaterals. Okay, this is very common in a post-Glenn type of scenario. This is actually something like the paravertebral plexus that seems to be filling up. And you know, there's nothing that you need to particularly do about this. So the next stage for this patient would be what would the next stage be? If this is a 6-year-old, you've just cathing who's had a Glenn before, you've demonstrated the IVC connection to the right atrium, saturation is 80%, what would you do next? Yes, correct. So you would complete his Fontan. Now, this is an additional finding in the patient. The same patient, okay? So what is this structure that we are filling here? What is the structure that we are filling here?
MIOT?
Not entirely sure. Dr. Siddharth? Dr. Siddharth, can you please switch your microphone off, please? Okay, so this is the innominate vein. Okay, so this is being a left SVC. This is a right innominate vein. Okay, and what I want you to do is to just note this collateral that runs downwards. This appears to be emptying into the cardiac mass. So this is a venous collateral that appears to enter the atrial mass, and because it's quite small, probably nothing needs to be done about it. But occasionally, when these collaterals are large, they can give rise to desaturation in patients who have had completed fontans. So just something to keep an eye on. If the surgeon can see it and if he can ligate it, then that's fine. Otherwise, this is a collateral which, a venous collateral, which is actually emptying into the into the heart, and so this can be a source of desaturation. If it is large and if there is a significant shunt through it, it can be a source of desaturation. Obviously, this collateral has a very tortuous course, and it would be difficult to coil. But if it had a more straightforward course, it may be possible to coil this collateral if there is a clinical indication to do it. Okay, but at this point in time, what this child needs is actually completion of the contact. Okay, so another angiogram. So a relatively rare angiogram. I've only seen it once in my life, but it's a nice angiogram and a special prize for somebody who comes up with a diagnosis. The complete diagnosis. So where is this? Where is the angiogram being done? Come on, guys, wake up, wake up. No, this is not the IVC and the SVC. What is this structure? Correct. So this is the descending thoracic aorta. This is an angiogram with a pigtail catheter. This is the arch, okay, and then the tip of the the tip of the pigtail is actually in the ascending aorta, okay. But what do you see? What is this? What is this here? What are we showing here? Come on. Anybody? Not seen this before? No, it's not arterial tortuosity. Yes, there are MAPCAs. That's correct. So there are MAPCAs and this is a double arch. So this is an unusual combination of a double aortic arch with pulmonary atresia with MAPCAs. So this patient has a double aortic arch. You can see, I'll try and freeze it so it becomes a little clearer. Okay, let's just move this back a little. Can you see the two arches? Okay, this is ascending aorta, the right-sided arch, which is seen here, and the left-sided arch here. Okay, and if I move it forward, you can see it filling further. Okay, the right arch, left arch, and you have, like someone mentioned, you have a lot of aortopulmonary collaterals that fill up. Because the collaterals are quite large, the runoff is very rapid, so you can't delineate the collaterals very clearly. They'll have to be selectively entered and cannulated using something like a right coronary catheter, and hand injections need to be taken. Okay. So that was patient with a double aortic arch and multiple aortopulmonary collaterals. Okay, so what is happening here? First, describe the course of the catheter. And then what is being done here? Correct. So what is the course of the catheter? Course of the catheter, quickly somebody? Where are we going from? This is pretty simple. IVC, RA, and then through the atrial septum, LA, and into the pulmonary vein. Very good. So you're wedging the catheter, and usually during this injection, you layer the contrast. So you have initially, you draw up some saline, and then you draw up some contrast, and you don't mix the two, so that you can give a quick, good volume injection, but not use too much contrast. So what you can see here with the reverse pulmonary venous wedge is that you have backfilling of the pulmonary arterial system. Okay, so you can see here that the pulmonary arteries appear to, you can see that there, can't you? It seems to end in a blind pouch. So there may not be any pulmonary arterial confluence, like there's just a beak-like appearance there. The other thing you notice happening is that you get a contrast entering the bronchus. So sometimes when you do this injection quite forcefully, you can get contrast entering the bronchus, during the injection. So that's the other thing that you can. Do you notice that going up? This child is ventilated, has an ET tube in. You can see that there is contrast going up the airway. So if the child desaturates or gets uncomfortable, you probably have to do a bit of suctioning. Okay, and then probably wait till the child recovers before you proceed. Okay. Right, so this is a 6-month-old with Down syndrome. Apologies for the inverted echo, but I hope that you guys can orient yourself to the upside down picture. So describe this echo. What can you see? This is the LA, RA, LV, and RV. Okay. Not so sure. See, basically, you can see a complete septum primum here. I don't really see a primum ASD here. And you can see 2 separate AV valves. I accept that this is on the spectrum of an AV canal. But the only lesion here is an inlet VSD. Okay, so this is a large inlet VSD with 2 separate AV valves. But the cause for concern here is the fact that, what do you notice about this valve? What is the important thing in an inlet VSD with regards to the AV valves and operability? Exactly. So you need to look for straddling and override and straddling, right? So there appear to be attachments from the left AV valve onto the right side of the interventricular septum. So these have to be clearly outlined to determine whether this VSD can be closed safely. Okay. Sometimes surgeons, if there are isolated cords, may be able to remove the cords and re-implant them. But this is a potential problem that you need to highlight to the surgeon so that they are aware that it's not going to be a straightforward VSD closure, and that the valve is kind of the valve chordae of the valve are attached on the opposite side of the septum. So this might be a little clearer. Okay. So you can see, I looped it. So you can see that the caudal attachments of the left AV valve are going across the septum, and this is going to be a potential problem. Okay, so that's so basically that's just an inlet VSD. It's not a complete AVSD. Complete AVSD, you'd have a primum ASD and an inlet VSD. It may just be that the inverted picture kind of caught you off guard, but that is just an inlet VSD. Okay, right. So next question, what is the catheter course in this patient and what is the diagnosis? Okay, this is a spotter. Correct. So this is very good. So this is IVC to RA into a smooth walled ventricle, which is the LV. Then the LV opens into the pulmonary arteries. And you have a levo phase as well. Is there anything you specifically notice about the pulmonary arteries? So although CCTGA is correct, it's not a complete diagnosis. Anything else you notice about the pulmonary arteries? Maybe better viewed in a lateral projection, but even here, and you can see this patient has had surgery, right? So what procedure do you think this patient has probably had? What can you see here in the pulmonary artery? No, it's not an atrial switch. The RA is still connected to the LV. Correct. So it's a PA band. So this patient is being prepared for a double switch operation. Has sternotomy. So it's important to notice all these things. Just saying this is CTGA is an incomplete answer. So patient has already had surgery, and you can notice that in the PA there is. Can you see that constriction there? So that is a PA band, and this is done in order to condition the LV for a double switch procedure. Okay, so this is the same patient. Now the lateral projection makes it quite clear, doesn't it? So you can see that this is the banded pulmonary artery. What else can you notice here? So what else does this angiogram beautifully show? The relationship between the great arteries. So the pulmonary artery is posterior and the aorta is anterior. Okay, and it arises from the trabeculated RV. So if you see the levo phase of this PA injection, pulmonary veins, LA opening into the RV and RV opening into the aorta. So a very nice demonstration of CTGA anatomy. Okay. Oops, let me just read the question first. So the question here is 2-month-old presents with breathlessness. Okay, 2-month-old with breathlessness. What do you see on this echo? Anybody? So what is this view that you're trying to get? It is what view is this? Bicaval. So it's a subcostal bicaval view, right? So what do you see here? Okay, showing SVC. So yes, correct. So this is SVC flow. SVC flow is generous, increased. Yes. What else can you see? I'll put my pointer as a clue. What else can you see? Oops. Oh, okay. Just because the SVC flow is increased, somebody has decided this is supracardiac TAPVC. Correct. So, Bala Ganesh, you're right. So this is right to left flow across the atrial septum. This is very, very important. You have to, recognizing this is very key. So what are the conditions where you get right to left flow across the atrial septum? So quickly tell me a list of conditions where you get right to left flow across the atrial septum. TAPVC, okay. Tricuspid atresia, good. Don't repeat it. Okay. Pulmonary atresia, intact ventricular septum, fine. Okay. What else? Epstein, yeah. Epstein is the other one where you get tricuspid regurgitation, atrial shunt, atrial septal defect, and often the TR jet is directed towards the LA. So you get a right to left shunt. And what else? In a neonate, what else can you get? The neonatologist will probably see it more. Yeah, in a TGA, you have bidirectional flow, fair enough, but the typical right to left flow, yeah, persistent pulmonary hypertension of the newborn, or any other severe PAH type of situation, you can have right to left flow. Okay, severe TR because of streaming, and I think we have covered everything. Okay, so what do you see here? Same patient. So we have a 2-month-old breathless. We have found right to left flow across the septum. Yes, vein of Galen is the other one, correct? What is this? What are your findings on this 4-chamber view? Slightly tilted. Quickly. Okay. More striking than the mild TR. What is very obvious? Okay. Hypertrophy. It's basically, don't you see that the RA and the RV are dilated? Compare them with the LA and the LV, right? Isn't there a size difference? So RA and RV are dilated. There appears to be some RV hypertrophy and some TR, mild TR. LV, I'm not sure whether there is hypertrophy. This view is probably not very clear. Definitely it looks a bit squashed. Okay. This is your TR gradient. And TR gradient is 65. So you have either, like we discussed earlier, a high TR gradient indicates that there is either some obstruction or there is pulmonary hypertension. Okay. So now we have a clue. What are we seeing there? What are we seeing there that normally should not be there? So this is a subcostal view, okay, which is quite posteriorly tilted. So quite posteriorly tilted subcostal view. This is the RA, RV. This is the LA. What is this? What is this? Come on, guys. Same patient. Correct. So this is a common chamber or confluence. Okay. Now I put color on it. You can see all the veins draining into the confluence, and there appears to be some turbulence. Okay. So this is, we have a generous SVC flow. We have right to left shunting across the atrial septum. We have pulmonary hypertension. We have demonstrated a confluence, and there are no pulmonary veins coming back into the LA. So this is, and we have a vertical vein that is going up. This is supracardiac TAPVC. Now, what does this turbulence mean? That the TAPVC is obstructed. Good. So what is the most common site of obstruction for supracardiac TAPVC? What is the most common site for obstruction? Correct. So it is the between the left bronchus and the left pulmonary artery. Okay. So this vice, V-I-C-E, is the bronchopulmonary vice. I think that's the name. But it's basically between the left bronchus and the left pulmonary artery. There is a narrowing of the vertical vein, and that gives rise to obstruction. And here you can see that there is a gradient. Normally, what are the characteristics of unobstructed venous flow? What is quite abnormal here, irrespective of the gradient. Normally with pulmonary venous or systemic venous flow, what do you expect with the Doppler tracing? Right, hemodynamic wise. Okay. Yes, exactly. So it should touch the baseline. So you see, it doesn't touch the baseline. That is a characteristic of obstruction. And here, if you see that it's about 2 meters per second, so the mean is not very different from 2 meters per second. Okay, so you're talking about a gradient of about 5 at least. So that's elevated. And more importantly, there is turbulence, and the Doppler trace does not touch the baseline. So this is obstructed supracardiac TAPVC. Okay. 10-year-old presents with cardiac failure. 10-year-old with cardiac failure. What is your diagnosis? So tell me, what projection is this in? This angiogram, what projection is this? Okay. So we have somebody who's come out, right. So this is not only LAO, this is LAO with cranial, yes. Quite steep LAO with a cranial tilt. So you can see that the diaphragm overlaps the cardiac silhouette. Okay, so this is LAO cranial. There is a pigtail catheter in the, there is this pigtail catheter in the LV, correct. And what you can notice with the injection is that the LV function, do you think the LV function is normal? LV function looks impaired. Okay, LV function looks impaired, and you can see the typical, this is the aortic valve, and you can see the typical, hourglass type of narrowing above the aortic valve or at the upper, kind of insertions of the valve. Now actually it's frozen in a very nice frame. You can see here, this is where the maximum narrowing is and quite close to the coronary arteries. So this is a child who actually has, what syndrome would this patient likely have? What syndrome is associated with supra AS? Williams syndrome. So actually this child has, this child has Williams syndrome. There is supra-aortic stenosis and it's quite severe. Okay. And it has resulted in decreased LV function. What are the causes of decreased LV function in supra-AS? One, of course, is the severity of the obstruction. What else can cause myocardial dysfunction? What else? What is that? Is that coronary? Yes. So I think absolutely. So the coronaries can sometimes be involved in the process, and there can be myocardial ischemia, with the myocardial damage and dysfunction. So, okay. Right. So what are the other features you look for? I think I've already put those features in. So cocktail personality, they have a typical facies. They often have bad teeth and hypercalcemia. So these are some of the other things. But the most characteristic thing about them is their personality. Okay. So this is, I think, another injection demonstrates the abnormality much more clearly. Okay, so I don't think there are any doubts, and you can see how close to the obstruction the coronary arteries are. And sometimes it's necessary to do selective injections to delineate in different projections to delineate the coronary arteries clearly. And surgery is the treatment, only treatment really. Patches are applied. There are different techniques, but often multiple patches have to be applied over the constricted area to widen the supravalvular portion. Okay. So next question, describe this angiogram. So what is the force of the catheter? So what is the course of this catheter? So where is the tip of the catheter? Where is the tip of the catheter? Where is this? Correct. So this is actually in a pulmonary vein. Okay. So this is in basically in the right pulmonary vein. Okay, lower pulmonary vein. So this pulmonary vein appears to be draining anomalously. So it appears to be draining anomalously. This is IVC, RA, SVC, and into the pulmonary vein. So this is anomalous drainage of the pulmonary vein. Oops. And the SVC appears to be, the heart seems to be in the right side of the chest. And this is a left-sided SVC. Okay. So perhaps a situation where there is situs inversus with the right atrium being on the left and the SVC being on the left, but with an anomalous vein draining from the right lower pulmonary segment. Okay. Okay. So actually we have already discussed this, but this is a very clear demonstration of the finding. Okay. So what are you seeing here clearly? Okay. Let's go back. Course is not clear. Right. So see, essentially, okay, this angiogram doesn't show the abdominal course of the catheter, okay, but this catheter has been inserted through the IVC, okay. It goes via the RA into the left-sided SVC. So what happens in situs inversus? What happens in situs inversus? Where is the SVC? It is inverted, right? So this is the left-sided SVC. This is the innominate vein, the right innominate vein. Okay, and this is an anomalous pulmonary vein draining into the right innominate vein, left SVC, left-sided right atrium. Okay, and IVC. So patient with situs inversus and dextrocardia. You understand that, right? Situs inversus and dextrocardia, which is why the RA is on the left. The SVC is inverted, so it is a LSVC with right innominate. Into this right innominate, there is drainage of an isolated right lower pulmonary vein. So this is partial anomalous pulmonary venous drainage in a patient with situs inversus and dextrocardia. Okay? I hope that is clear now. Okay? So it's just an inverted, inversus type of situation. That is why it's confusing to you. Okay, so just a quick one here. What are we seeing here? What am I showing you here? Right, so it's an atrial shunt, which is, what is abnormal about it? Right to left, yes. So just saying PF4 is not enough. The striking thing is, an atrial shunt, probably a stretched PF4 with the right to left shunt. Now we've already discussed why that happens. So what is the same patient? What does the echo show? What does the echo show here? Hypoplastic RV. Perfect. Okay. So very small RV. You have a dominant left ventricle. You have a hypoplastic RV, and the tricuspid valve looks very small. So hypoplasia of the tricuspid valve and the RV We don't know about pulmonary artery from this shot. But yes, pulmonary atresia appears to be there. And what is this flow that you see here? So this is a 9-month-old baby who's never had surgery before. Yes. So has a patent PDA, which is what has kept the child alive. So what is the surgical strategy next? What is the next step you would consider? So pulmonary atresia with ducts, supplying the pulmonary arteries. Pulmonary artery RPA at least appears to be of a decent size. LPA needs to be further evaluated. So here the tricuspid valve is very small. Okay, I'm getting many answers. Hold on, not the right answer though. Finally, the right answer. Okay, so if you look at the right ventricle, first of all, you would think of an RV to PA conduit, etc. if you think that the right ventricle is salvageable. So as part of your evaluation, you need to evaluate what is the size of the tricuspid valve, take the Z-score of the tricuspid valve, and looking at the RV here, there's only an inlet portion here, a very trabeculated RV, very small RV. Of course, just this one view is not going to help you make the decision, but this is probably an RV that we may not be able to salvage. Okay, this patient is 9 months of age, and if you have a significantly hypoplastic RV and tricuspid valve, then probably not suitable for a biventricular repair, and you would probably think about a bidirectional Glenn as a first step of palliation. If on your assessment you feel that there is adequate RV cavity, then you could try and core out the RV muscle, but a lot depends on the tricuspid valve Z-score as well. The tricuspid valve here looks very small to me. So whatever the RV may be, if the tricuspid valve is very small, then it may not be possible to actually achieve a biventricular or 1.5 ventricular repair. But yeah, definitely needs further assessment the RV, but this heart is not going to be one for a complete biventricular repair. So DDG is going to be a critical step in the surgical treatment of this patient. Okay, so before we start, so as soon as I show you this still, what does this picture show you? Even before we run the angiogram, just the cardiac silhouette. Can you make any comments on it? Yeah, it appears to be that the apex is up tilted, right? So there's a boot-shaped kind of silhouette that we can see. This could be the thymus, we don't know. Okay, so yes, it is the thymus. So once again, what is this procedure being carried out? Yes, wide superior mediastinum. In this case, it is because of the thymus. Right. So IVC, RA, LA into pulmonary vein. So this is just like we discussed earlier, a reverse pulmonary venous wedge that is being carried out. And it's like I told you, the technique is layering of the contrast and saline. And you can see very nicely that the distal arborization of the left pulmonary artery is clearly seen. Okay, but we see that it is blind ending. So the branch piers are probably not confluent. From this angiogram, what other feature can you make out? What other feature can you make out from this angiogram that this patient has? Commonly associated with, so this is most likely the very fact that you're doing a reverse wedge means you're not able to get into the pulmonary artery. Okay, I'm looking at the state of the the fact that this small PA and is disconnected, what is the likely underlying diagnosis? Disconnected LPA, what is the likely underlying diagnosis? Pulmonary, TOF pulmonary atresia, right? Pulmonary atresia is highly likely because of the fact that you're having to do a wedge and it's definitely the LPA is disconnected. Okay, the RPA may be connected to the MPA, but most likely this is a pulmonary atresia patient. Pulmonary atresia, and what other associated finding can you see? Which is quite common in patients with pulmonary atresia. Quickly. Very obvious. Correct. Right arch. So you can see clearly actually the bronchi are very nicely delineated here. This is the right bronchus, the left bronchus. Right bronchus is more, kind of in line with the main bronchus. Left bronchus is a little bit more acute. And the arch goes around the right bronchus. So that is how you define a right arch, that it should, arch over the right bronchus. So that is the right arch. And the first branch of a normal branch of a right arch would be the left innominate. Okay, so see, there you go. So that's the first branch, the left innominate, giving rise to the left common carotid and the left subclavian. Okay. Okay, so right, we're on the same patient here. So we saw the, you can see the same boot-shaped heart. So can you describe the course of the catheter to me now? Tell me the course of the catheter. IVC, no, this is not in the pulmonary vein. The tip of the catheter is in the aorta, right? RA, RV, exactly. So this is just going from the RA into the RV via the VSD, because this is usually only TOF, pulmonary atresia, VSD. So you've gone across the VSD into the ascending aorta. This is the right arch, like we discussed earlier. Okay, so this is the ascending aortic course. Arch is going down. So you can clearly see the branching pattern. So the first branch of the right arch is the left innominate, very nicely demonstrated. Then you have the right carotid and then the right subclavian. What is the finding you can see here? Remember that left pulmonary artery, right? So what is the finding you can see here? What can you see here? Correct. So there is a remnant of a PDA from the innominate, which was supplying the, entering or inserting into the left pulmonary artery. So when that PDA constricted, it caused disconnection of that left pulmonary artery. Okay. So that explains why that LPA got disconnected. So this is a patient with pulmonary atresia VSC who has a disconnected LPA. Maybe, could be a TOF as well. Has a disconnected right arch and a disconnected LPA because of a PDA constriction, PDA from the innominate. Okay, so I think we've done that. Okay. Right, so describe the catheter course. Okay, so if you look at the entire angiogram, right, there were no MAPCAs on that patient. Fine. Yeah. So that, yeah, there are no MAPCAs. Somebody had, for the previous patient, somebody has mentioned MAPCA. We have not seen any MAPCA on the angiogram. What we saw was actually a PDA, which had constricted. Okay, so now we move on to the next patient. Quite a complex patient, but just use logic. And in fact, the angiogram itself tells you a lot of information about the cardiac structures. So this is just in a standard frontal view, the post-operative patient because of the external wires. Right, tell me the course of the catheter. IVC, RV, RA, RV, into the pulmonary artery, into the RPA. Okay, so Dr. Akshata is kind of getting close to it. So up to RPA is correct. So where is the tip of the catheter actually? Where is this? The patient has had a procedure. Remember, the patient has had a procedure. So try and think of what procedure it could be given this catheter course. Okay, this looks like an azygous vein. Perfect. So where does the azygous enter usually? Into the azygous enters the SVC. Yeah. So actually, this is the course of the catheter is IVC, RA. It forms a loop in the RA, RV, pulmonary artery, RPA, and then the SVC. Okay. So what procedure has this patient had? So you've gone from the RPA into the SVC. Why do you say Kawashima? Glen. Absolutely, yes. This is a pulsatile glen. Correct. So the RVOT, perfect. RVOT has been left open, so there is forward flow. And this is a glen because there is a connection between the RPA and the SVC. So this is a pulsatile glen. Now, unfortunately, this patient is, do you think this patient's glen is working fine? It can't be because there is a huge dilation of the SVC and there is this huge azygous vein that has become dilated. Okay? That is the SVC, what you're saying there. So what has gone wrong here? Just pay attention around this area. Oh, sorry, hold on, sorry. I'm trying to freeze it at a frame that's a little, okay, that's it. Okay, so at the back you have the, azygous vein, so there is a bit of superimposition. This is the SVC, it's dilated, but at the point of anastomosis, can you see how it is quite constricted? And also part of the pulmonary artery here, you can see some stenosis. So there is dysfunction of that glen anastomosis. So it has there is narrowing of the glen anastomosis and also narrowing in the pulmonary artery. So this needs to be redone. Okay, so this is a patient with glen obstruction, which has resulted in huge dilatation of the SVC along with the dilatation of the azygous vein, which as a result of the high venous pressures. Okay. Okay, so this is a slightly complicated angiogram. Patient has quite a rotated heart. Okay, so basically, where is the injection being performed? Correct, distal anastomosis. So yeah, where is the injection being performed here? Appears to be an end-hole catheter. Can't be sure though. Yeah, it is an end-hole catheter. So must be a hand injection. This was a small, so like a neonate, a small baby. Okay, the injection is not in the RV. So this, if you see, we don't have the, it seems to be not the entire chest is covered, but the heart is pretty rotated. So you have an injection in the IVC, where the hepatic veins come in. What you see go across here is actually the atrial shunt, the RA, RV, and then the PA. So it's a very rotated heart. Can't make too much out of it. Okay. This is a little better. It's the same patient, huh? Same patient. So here you have an injection into the descending thoracic aorta. Okay. And what I want you to pay attention to there appear to be some collaterals coming off. Something coming off here and here. Oops, let me just see another one here. Okay, so all of these are the same patient. So here, so on the first angiogram, I kind of told you about the structures, right? IVC, RA, RV, pulmonary artery. So this is a selective injection into the RPA. Okay, so can you tell me what's absolutely? Yes. Yes, this is a patient. Now, one of the first clues when you see this angiogram is that the heart is shifted to the right chest. So whenever you have the heart shifted to the right chest, you know, not dextrocardia inversus type of situation, but when you have it shifted or pulled to the right chest, one of the things you have to suspect is a Scimitar syndrome, where you have anomalous drainage of the right lower pulmonary vein. So this is an injection into the right pulmonary artery, a selective injection into the right pulmonary artery. And you can see that in the late frames. Okay, let's just treat this and then take it back. So this is the injection into the artery. The veins are filling in. Okay, and you can see that the right upper vein enters the left atrium. Okay, but if you look here, which is the right lower vein, you keep following them. You see, they form pulmonary venous channel which enters the IVC. So this catheter is actually in the IVC, RA, RV, and it has come into the RPA. So this is a very nice example of the Scimitar syndrome. Okay, so you have anomalous drainage of the vein, and on the previous angiogram, we saw how we had some. Okay, done that. Okay, so we saw how we had this was injecting into the descending thoracic aorta. We saw that we had some anomalous arterial supply as well to the right lower segment. Of course, that has to be shown in a clearer fashion. Okay, but yes, well done. Okay, so what is the diagnosis here? Echo seems projection I'm not very happy with, but anyway, so what is the diagnosis here? Course in the previous. Okay. We'll go back to that. We'll finish this and we'll go back to that. So, what do we see here? What is the diagnosis? Okay, so there is some fluid in the pericardium. There appears to be some diastolic flattening of the RV. So on M mode, you can see that you know, there is fluid in the pericardial space. And what do you notice about the pericardium here? Anything that you want to say about the pericardium here? There is some. Yeah, so there is some thickening of the pericardium. Okay, normally the pericardium is only about 2 millimeters in thickness. Okay, this I think measured about 5 millimeters. So there is some thickening of the pericardium. Also, it was noted that there was with the Doppler, velocities during inspiration and expiration, there was a significant variation in the inflow velocities across the mitral and tricuspid valves. and flow reversal in the hepatic vein Doppler. Okay, so all of these together would suggest that there is not restrictive pathology. This is constrictive pericarditis. Okay, so why do I say it's not restrictive? Is because first of all, there is pericardial fluid, there is pericardial thickening. Okay, normally when you have a restrictive problem, you have, okay, so yes, now I remember what I wanted to point out to you on this echo. When you have a restrictive problem, you have a disproportionate dilatation of the atria. Okay, so you have a disproportional dilatation of the atria. It looks like Mickey Mouse's ears when compared to the ventricle, but you don't really see that here. So this is not in restriction. You will see the significant biatrial enlargement. You will also see possibly some tricuspid regurgitation, which will be a little high velocity because the RV restrictive process makes it less compliant, and it makes the RV pressure go up. So often you will have RV pressures in excess of 50 millimeters of mercury. So high RV pressures will be seen in restriction. That will not be seen in constriction. If you look here, you will notice that the septum has a funny bounce about it. Okay, so on the M mode, I think that's what I wanted to show you. So you can see this. Okay, this kind of a bounce that is seen. This is the normal contraction. So normally you will see relaxation, right? But you see that there is an inward motion of the ventricle of the ventricular septum towards the LV. Now this is because of the phenomenon of ventricular interdependence. So because the pericardium is constricting the ventricles, they cannot expand outwards. So in diastole, initially, the RV fills quite significantly, and because it is not able to expand outwards, it expands towards the septum. So that causes that septal bounce. This is a typical septal bounce that is seen in, constrictive pericarditis. And of course, here you can see thickening. What is the advanced imaging modality that can be used for assessing, constrictive pericarditis? What is the advanced imaging modality that is used? Correct. So CT is the additional advanced imaging modality. CT is traditionally used. That can be used to determine, whether there is calcification in the pericardium, what is the pericardial thickness, etc. Okay. Yeah, that's what I had forgotten to mention as I breezed through these slides. And then we talked about the respiratory variation. Hepatic vein flow reversal. So, normally there should be no significant reversal of flow. So everything that is in the positive of this axis is reversal of flow. Normally the hepatic vein drains, downwards, away from the flow on this cut. But you can see significant flow reversal that is seen, and this is exaggerated or more during inspiration. Because of increased venous return to the RA, which then backflows into the hepatic vein. So this is another characteristic feature of constrictive pericarditis. Okay, so I think we've come to the end, but sorry, I wanted to go back to that angiogram. Okay, so I think this is the one that you had some confusion about, right? Okay, so here what has happened is that this patient, you remember, had a PFO. Remember the first angiogram that I showed you? I showed you a PFO, this one. IVC, you see that PFO? Okay, so what we have done here is gone IVC, RA, through that PFO, okay, into the LA, and then the LV and aorta. Okay, this heart is pretty rotated, so I can understand that it's not altogether clear. But here what we have done is gone across the atrial septum into the left side of the heart, LV, and then into the aorta. Okay, I'm not entirely certain whether there was a PDA in this patient. I'll just have to go back. The aorta seems very low in position. I'm not sure whether it's just, we should see that. But you can see that, you see the aorta fills up here, which I think is pretty much where we have gone. So the heart is quite rotated to, altogether. So that was the course. Just put that on again. No, not what I wanted to show you. So I think we have gone LV into the aorta, but yeah, I think this heart is not a very normal heart. So the position of all the structures is a little off. But I think the important thing is when you see the cardiac silhouette pulled across to the right, it's important to remember scimitar syndrome and look for it. Okay, so I think with that we've kind of come to the end. I hope it's been an interesting session for you and that you've seen a few cases that have been out of the ordinary. Okay, all right. So I think we'll wind up now. All right, okay. You're welcome. Thank you. Bye-bye.